Hello and welcome to the Imaging Wire Show. My name is Brian Casey. I'm managing editor of the Imaging Wire. Got a great episode for you today. Our topic is CT lung cancer screening. And our guests are Dr. Lary Robinson of Moffitt Cancer Center and Liv Egan of Siemens Healthineers. Dr. Robinson, Liv, thanks for being with us today.
Thank you for the invitation.
Thanks for having us, Brian.
You bet. So let's start with introductions. And if you could both tell us a little bit about yourself, that would be great. Let's start with you, Dr. Robinson.
Yes, I'm a thoracic surgeon. I've been here at Moffitt Cancer Center for about 30 years, and I currently run the Lung Cancer Early Detection Center, which involves our indeterminate lung nodule clinic, our surveillance clinic, and then our Moffitt screening program. So
Right,
I'm quite interested in this topic, and it's really what I do for a living now completely.
Great. Liv, how about you?
Egan, I'm the Director of CT Product Marketing here within Siemens Healthineers and look after all of our mobile lung screening solutions. Something that's very passionate and close to my heart as an ex-CT technologist, and been very privileged and fortunate to work with some amazing customers that are visionaries in this space, such as Dr. Robinson and the Moffitt Cancer Center. So thanks for the opportunity to chat to you today.
Oh, you bet. It's our pleasure. So CT lung screening has kind of been around for a long time, since the NLST and the Nelson studies came out and showed that it really is an effective test for reducing lung cancer mortality. And the USPSTF recommended CT lung screening, gosh, I don't know, maybe back in 2013. So it's been a long time. And it kind of languished for a long time, but now it seems like it's really gained a lot of momentum. And there have been so many studies that are being presented at meetings that show how to do the test and how to effectively carry it out. Dr. Robinson, can you talk to the problem of lung cancer incidence and mortality and how much of an issue it is right now around the world?
Well, lung cancer itself is a massive problem. I think it's underappreciated by the average person. Don't realize how bad lung cancer is. There's probably, for example, there's nearly 250,000 new lung cancer cases in the United States every year, at least 2 million nationwide or worldwide. And the other problem is that it kills so many people. Every year, probably at least 130,000 people in the United States are going to die of that disease. That's about one person every 4 minutes. Just to give you some relationship to what that means, that's like the entire population of Gainesville, Florida, home of the Gators. If everyone in that city died every year, that's 130,000 people. So it's an enormous problem that we're trying to address by finding lung cancer early when it's curable. As you can see on the slide, the yearly death rate equals the next three cancers combined. If you take all the people who died from pancreas, breast, and prostate cancer, that equals just about the number of people who die from lung cancer. So it's one person every 4 minutes. And if you just take everyone combined, without looking at smoking, every 1 out of every 16 people will get lung cancer. And what the new problem has been over the last 15, 20 years is never smokers get lung cancer. Women particularly, 25% of the women who get lung cancer are never smokers. I see at least 1 or 2 in my clinic every week, never smoking females with lung cancer. It's about 5 to 10% of males. And the survival rates are the highest when you can find it. But unfortunately, we only find lung cancer maybe in 25% or so of the people who develop cancer. And usually those are all people who are without any type of symptoms whatsoever. And that's why lung screening is so extremely important. Cure rates are also very high when you find lung cancer early. This just gives you an idea. This second slide really shows you what the eligibility criteria has developed currently by the USPSTF, which is a mouthful by itself. The recommendations are currently anyone over the age of 50, those who have at least a 20-pack year history of smoking. That's like 1 pack a day for 4 years, 1 pack year. And then if you're either a current smoker or quit within the last 15 years, if you take all those people in the United States combined, that equals roughly, we figure, about 15.3 million people. Now, if you could get all of those people, which is about the same population of Pennsylvania, if they could all get screened, we'd find enough cancer to save about 80,000 lives every year. That's equals about twice the number of people that could fit in the Washington National Stadium. That's an awful lot of people could be saved from dying from lung cancer. The problem is lung cancer screening is the newest thing. There's a lot of unaware people are not aware of its necessity, so that currently maybe 10, maybe 15%, I think 16% is kind of optimistic, of the people who are eligible to get screening actually have a lung cancer screening done. Breast cancer, which has been around for a lot longer, screening, mammography, at least over 75% of the women who are eligible for screening get screened. Same way with colon, prostate, and cervical cancer. Lung cancer screening is the new kid on the block, so it takes a while to try to make people aware of it, both providers and the population. And the problem is there's also it's limited to certain individuals who get screened. For a breast cancer screening for mammography, the people who are eligible for screening is if you're over 45 years old and you have breasts. That's not the case with lung cancer. If you have lungs, you have to meet those criteria. And I think those are appropriate criteria, although we'd like to see them broadened, and hopefully that'll happen in the next few years. It's also very effective. Lung cancer screening is extremely effective. It takes about to save one person's life, it takes a little over 300 screenings to save one person's life with lung cancer screening. Breast cancer, it takes at least 1,500 mammograms, 1,500 women to get mammograms to save one woman's life. And it's far cheaper. That's why insurance companies are happy to pay for lung cancer screening, because it's much, much, much cheaper to treat somebody with stage 1 resectable, removable, treatable lung cancer compared to the average cost, which is much higher for patients who have advanced cancer or metastatic cancer. And those folks are about 75% of the people have the advanced cancer. So they'd much rather have us see people who are early stage disease, and those people who have disease and are saved from lung cancer. If they're young enough, they go right back to work. They go back to, doing whatever they want to do. So they're also productive members of society. They pay taxes. They go on trips, and they work. And many times when you get advanced lung cancer, it's very difficult to get back into working and a lot of the normal activities. So what we've done is really tried to enhance our screening efforts to find people with lung cancer early. Moffitt has been very committed to this. We've been for a long time using brick and mortar, and that is, fixed sites at the cancer center and the various our outreach areas, and people come and get screened. Sometimes the problem is, and we're in a large city, is that a lot of individuals are reluctant to drive into town. Now, it doesn't sound like a big deal, but if you live outside of Tampa very far, it's kind of daunting, the idea of going through the traffic to get into town to a place where they get screened. And what's really been a godsend to us in the last year has been our mobile screening unit. This is a picture of it. You can see it's a great unit. It's completely self-contained. It's essentially a big truck that has its own generator, has its own air conditioning unit. It's got a CT scanner in there. You can drive up anywhere. Literally, you could drive up to a gas station, stop, put down the blocks, and open the doors and turn on the lights, and you're ready to screen. It's very effective. We can screen about one person every 15 minutes. Actually, since we've started, they've gotten very efficient. Now they're down to about one person every 5 minutes. We have people screened. They get scheduled ahead of time, and all they do is walk in that door on the right. They sign in their name. They walk through a door into the CT scanner, lay down, hold their breath. It takes about 15 seconds for a CT scan. Get back up, walk out the other door. It's really, it's amazingly simple, painless, and it's very effective. And we've become, people love the fact and the convenience. And this unit's been very effective. We're just terribly pleased with it. And our screening has gone up dramatically with it. It's gone up in the last year. It's gone up 30% more screenings just with the addition of our mobile screening unit. One of the problems about brick and mortar sometimes is, particularly if you go to a place that says cancer center on it, people are a little reluctant to go there because, if I go to a cancer center to have screening, they think in their mind, well, maybe I actually have cancer, and they're a little reluctant to try to go there and have a screen. So going to a mobile screening unit, they're very happy to do that, much more so. So we're just elated to have this available for us.
Dr. Robinson, what do you think has been behind some of these low screening completion rates that you noted? 16%, the number seems to be between 10-20%, depending on the study. Why is it so low? And to what extent do you think mobile screening and bringing screening out into the community is going to change that?
Well, there's a number of reasons. Probably the biggest one is a single word: awareness. People are just not aware that this is an appropriate thing to do. I've talked to so many people. We're talking about very highly educated individuals who are quite aware of everything about their health. And you'll talk to them and they say, well, I stopped smoking 10 years ago. I'm fine. Well, you're not fine. You're not necessarily fine, and you're at elevated risk. So people are not aware that it's important to do. There's other problems. They're concerned about the radiation exposure. But we use low dose screening CT scans, which give you the amount of radiation, about half of what you get every year just by being on Earth from, radiation from the sun, cosmic rays, and so on. There's some stigma about lung cancer screening, particularly if you're a former smoker. I sort of caused this myself. So that's another reason. So there's a lot of reasons. Sometimes it's not recommended by my doctor because the doctor may not be aware that this is something appropriate to do. And finally, one of the problems can be, as I think I indicated earlier, it can be just availability. People are sort of, they live out in the a little more rural area. They could be, 30 miles from Moffitt, yet they're a little reluctant to drive into town to some big center or someplace. A lot of people, don't want to do that. And if you go out with your screening unit and they know about it ahead of time, they're at a local health agency someplace out in the local area, man, people are much more likely to show up there. And that's one of the things that's really been our screening folks. More people have said, gosh, I'm so glad you had this available closer to us so we could get screened. And they get screened a lot. And we're just, not overwhelmed, but we're really going quite well with this, particularly since we've gotten so efficient at it. I mean,
Yeah,
one person every 5 minutes goes in and out. And of course, the other thing happens is the screening information, the electronics are sent electronically over to the hospital where our thoracic radiologists read the screen. Then we call every patient within 5 days to tell them whether or not they had any abnormalities. And we don't just let them find out on their own. We also send them a letter, but we call them to let them know what's going on so they know what happened. And so you don't have to sit there and worry about it.
yeah,
I
that's
think
great.
there's a number of ways we can overcome this.
Yeah. Now, one of the things that I've been noticing in some of the studies that we've been covering on the imaging wire is the importance of patient outreach in getting people in. And it seems like, unlike mammography where women almost, as long as you meet the guidelines, they kind of self-refer, it seems like it's really important to kind of work a little harder to get those patients. What are you doing there at Moffitt to find out who's eligible and kind of reach out to them and say, hey, you're eligible for this test, it could save your life?
Well, I think it's, again, education of the providers, education of the patients. I do a lot of outreach visits to local practices to make sure they're aware of the requirements, the recommendations, exactly how to even fill out the forms. Sometimes if you don't put in the right number for the test, it'll get turned down, and not because the patient didn't qualify. They just happened to hit the wrong button on the computer. So there's a lot of problems about that, but we want to indicate to the providers that how important it is. So I give a lot of talks either in person, locally. I also give talks to the lay groups. Many times I'll go to a large women's club and church groups and just explain about lung cancer. Because like I say, there's a lot of, I don't want to say ignorance, just knowledge. They don't have enough knowledge about lung cancer, its importance, and who's eligible and who should get screened.
It's a big awareness issue. Now, Dr. Robinson, what do you do there at Moffitt if you if you have a positive CT lung screening exam? What's the follow-up procedure like?
Well, the importance is not just doing the screen, but doing something about it if you find it. probably around 10% of the patients who have a screen who meet those criteria will have some abnormality that needs a little further follow-up. And we've changed it. There's what's called a lung rad score, 1, 2, 3, and 4, that the radiologists read. And people who have a 3, for example, have a lung nodule that's, say, over 6 millimeters in diameter, which is like a quarter of an inch, and needs to just be evaluated. It's probably benign. And if it's if it gets larger than 8 millimeters, it starts to get a little, because size matters in terms of nodules and things you find. So those individuals need to be followed up. And what we're really stressing is we call patients who have nothing or very little, if anything, let them know that. But if they have a formal a screen that's worrisome or concerning us, they need to be followed up. We make sure they indicate they know this is the case. And then we have a indeterminate lung nodule clinic that I run. I see around 18 to 20 new patients a week. We get people in to see them, to evaluate them, and follow all the guidelines. And the importance is to follow the guidelines in taking care of patients with lung nodules. Way too many biopsies are done. Way too many things are done by, if you don't know, aren't used to seeing patients with lung nodules, many times inappropriate things are done. So we run the lung nodule clinic, and that's all we see. And we're able to, I think, be very efficient and make sure that patients know what's going on and make the appropriate follow-ups.
Perfect. Now, Liv, let's talk a little bit about what you at Siemens Healthineers are experiencing around CT lung cancer screening. What are you hearing from your customers? Are their experiences similar to what Dr. Robinson is describing?
Very much so, Brian. I mean, I think, in recent years, we're seeing a significant increase from customers who are running established lung cancer screening programs in their brick and mortar facilities, who wish to really provide greater access to this screenings program and trying to help break down those barriers that Dr. Robinson described. We all know that when screening is done with low-dose CT, it detects lung cancer earlier, it's more treatable, which not only improves survivability, but also reduces treatment complexities and cost for the healthcare facility. And many of our customers are looking to expand their lung screening programs out of that brick and mortar environment and into the community and set up mobile CT lung screening programs. So, thereby taking the CT scanners directly to where their patients live and work to break down those barriers. And this has been especially impactful in rural and underserved populations, but also in densely urban populations where maybe underserved communities that we don't often think about. We think rural access to care often, but we don't think about, city populations. But I think Dr. Robinson alluded to for the greater Tampa metro region. And of course, success depends on more than just the scanner. It's about having the right risk-based selection, follow-up pathways in place, the infrastructure. But overall, what we're seeing is that customers who are committing to these mobile programs are not just improving outcomes, they're redefining access to care in what is a really, truly meaningful, tangible way.
Yeah. And so Siemens, so we looked at we saw Dr. Robinson showed a picture of a mobile coach earlier that has a scanner in there. So that would be a Siemens scanner. What model are you guys offering with these mobile coaches?
It's a fully diagnostic CT scanner. It's the Somatom Go Up CT scanner. Ultimately, this concept came about because as Siemens Healthineers, our vision is to really provide quality healthcare and make it available everywhere and to support our customers, help their patients. And with this self-contained mobile lung screening solution, this is what we're doing. Mobile CT is not new, but what's unique about this is it's self-contained. And I think, Dr. Robinson mentioned that there's no barriers to where we can take this self-contained mobile solution. And so, when addressing that access to care, taking the screening program into individual patients' communities rather than having them to make the journey to the hospital environment. That Go Up scanner is a fully diagnostic scanner. It's installed on a cab and chassis truck. So think of it as, a large delivery truck. It has a powerful generator mounted on the back, which meets all of the power requirements that are needed to power the scanner, the, environmental, so heating, air conditioning, and lighting. And unlike the more cumbersome trailer mobile CT, it doesn't require a dedicated trailer pad, and so it doesn't need shore power. It lends itself to going wherever. It's easier to drive, much more maneuverable and flexibility. And then, the CT scanner offers the ability to acquire high image quality, and also utilizes what we call within Siemens Healthineers our mobile workflow concept. So it allows the technologist to spend more time with the patient, which I think is really important also within this screening environment. You want to make them feel comfortable. And then the user interface is very, uses powerful AI, embedded workflow with My Exam Companion, to really simplify the CT acquisition and the post-processing with Go technologies. And so ultimately what this self-contained unit design is allowing that screening program to go into the community and meet the patient's needs, and really bridge that gap between innovation and access.
Perfect. Now, Dr. Robinson mentioned radiation dose a little bit earlier, and he mentioned that some patients were a little worried about getting screened because of the radiation dose, but it's literally called low dose CT, and the doses already are really low. Liv, can you talk about some of the technologies that Siemens offers that can get dose down even further?
Sure. Well, within a screening program, what you want to do is, you really want to balance that risk benefit. And so you want to reduce the risk with dose efficiency for the CT imaging chain. And so there's it's the entire imaging chain that have dose saving technologies. We have dedicated lung cancer screening protocols. We achieve those low doses with the Stellar detector, which helps, be a lot more efficient with the radiation dose. But what ultimately helps achieve the symptom go up, limit the radiation dose, and turn a low dose CT into an ultra low dose is a particular Siemens unique technology called tin filter technology. And what the tin filter technology helps specifically within a lung cancer screening environment is it shapes the beam. In essence, the tin filter removes or filters out those lower energy X-ray photons from the beam before they reach the patient and the CT detector. And these low energy photons contribute typically relatively little diagnostic information, Brian, particularly within the lung fields where, the contrast between the air and the soft tissue, but contributes to the radiation dose. And so in the context of lung CT screening, where you're scanning large numbers of high-risk patients and often repeating that scan on those patients annually, you want to minimize the radiation burden, but without compromising the diagnostic confidence. And the GoUp technology helps make sure that we're delivering doses well and truly below the AAPM, dose threshold for lung screening, which is 3 milligray.
That's great. So our time's about up, but Dr. Robinson and Liv Egan of Siemens Healthineers, I'd like to get maybe some concluding thoughts from you, and maybe Liv, if you could go first. It seems to me like we're really seeing a lot of momentum behind CT lung screening, and it kind of didn't go anywhere for some number of years after the USPSTF recommendation, but that seems to really be changing. Is that kind of your impression, and where do you see it going in the near future?
Absolutely. I think mobile lung screening units are one of the most effective ways to bridge that gap between innovation and access. And, the reality is sadly that for many people at the highest risk of lung cancer, especially those in rural areas, lower incomes, veteran population, they have inherent barriers to traveling to a hospital environment. Dr. Robinson described many of those. Having a mobile CT scanner that's not going to compromise on the image quality, that's going to deliver a low radiation dose, but facilitates ease of movement of that mobile, can go anywhere in a community environment, eliminates that barrier because you're taking it directly to where the patients live and work. And we know that what's really powerful with early detection is it saves lives. And so by making screening approachable, we're not just detecting disease earlier, Brian, we're changing outcomes, improving quality to care. And it's really exciting to be able to support people like Dr. Robinson and other, screening programs out there to be able to do that.
Definitely. Dr. Robinson, some concluding thoughts from you, maybe where you see CT lung screening going, and mobile screening's contribution to that.
Well, I think several things that going to happen over the near future, and that is increasing the people who may be eligible. Right now, for example, there's a cutoff of, quit than 15 years of smoking. Well, the American Cancer Society, the NCCN, National Comprehensive Cancer Center Network, has recommended or has stopped that being a requirement. So that's because people don't just stop being eligible to get lung cancer because it's 15 years ago. It continues the rest of their life. So they've already taken that off, and we're hoping the USPSTF will take that off in the near future. The other thing that has been shown very well is it's the length of time you smoke. It's not the intensity, by saying it's not necessarily one pack a day for 20 years. If you smoke for 20 years, you have an increased risk. And particularly this has to do with underserved minority populations. For example, African Americans get lung cancer with much less intensity of smoking. And so there's been studies where they've looked at African Americans and Hispanics. And if you take away you do screening on individuals who say have 20-pack-year history of smoking and change it to 20 years of smoking, then you bring in a number of individuals and you actually sort of level the playing field. So those are two things, the first things that we hope will change in the very near future. And there's a lot of other risk factors we need to address, and hopefully that's going to happen soon. If you had everyone screened who's eligible right now, you'd find probably about 60% of lung cancer. 40% we still wouldn't find. So those are individuals who have other risk factors, and we're trying to sort out who should have those screening CT scans done. So I think that's a very important point about this that's going to change in the near future. And then mobile screening. What's so neat about mobile screening? It's people see it. They see the machine. They go by a hospital all the time, don't think anything about it, but they see a CT scan screening unit. I can't tell you how many times. For example, went up to they had a mobile screening clinic, if you will, for our unit up here at the YMCA. And I was standing there, and a few people came up to get their screens, and a whole bunch of other people who were coming out of the YMCA wanted to know what that was about. They had no idea about it. I mean, so it's something that raises visibility of screening even more because there's a visual unit out there, and of course the media love it too because it's it's a beautiful unit, and it really is something to show off, and it brings CT screening more to the forefront.
That's great. Well, it's a really exciting time to see the momentum growing behind CT lung screening. Well, I'd like to thank Dr. Lary Robinson of Moffitt Cancer Center and Liv Egan of Siemens Healthineers for being our guest today. Thank you both.
Thank you.
Right.
Signing off for the Imaging Wire, my name is Brian Casey.